the Advances in Prostate Cancer Diagnosis, Treatment, Decision Support and Supportive Care event. Now it's interesting, the medical profession seems to be even better than the IT profession in writing very, very long subject matters. Quite ridiculous. I'm Ian Dennis, I'm your MC for today, and a prostate cancer veteran myself. First of all, I'd like to acknowledge the Wurundjeri people who are the traditional custodians of this land upon which we meet today. I also pay respect to the elders, both past and present, of the Kulin Nation, and extend that respect to other Indigenous Australians present. So welcome. Quick housekeeping for those who haven't found them yet. The closest bathrooms are straight through these doors, and then it says in my script here towards the right, but that's absolute rubbish, that's to the left, so go that way, otherwise you won't find it. Okay? Could you also please switch your phones to mute? And please note that these proceedings are being recorded for podcast later, and so we can get some of the proceedings to regional Victorians who aren't able to attend us today. The WCMICS team very much appreciates your presence and hopes you find today's program informative. This morning we look forward to 5 guest speakers who will provide you information about a variety of aspects of prostate cancer treatment and understanding and support. And these are followed by refreshments out there, so we'll get some more coffee later. So let's get started. Just before we start, however, there is a feedback form which will be over on the table there, and if you don't fill them in, you're not allowed out. So please feel free to do that, and be as insulting as you like. The guy back there, you can say anything rotten you like, okay? Okay, right. So our first topic is advances in medical imaging for prostate cancer diagnosis. And our speaker is Associate Professor Declan Murphy. Declan is a consultant urologist and director of genitourinary GU oncology at Peter MacCallum Cancer Centre in Melbourne, an honorary clinical associate professor at the University of Melbourne. He's an internationally recognised key opinion leader in GU oncology, prostate cancer in particular. And he will speak for 15 minutes, followed by 5 minutes for questions. And he's dressed in scrubs because he's going straight over to surgery later. Please welcome Declan Murphy.
Thank you, Ian. I've broken the microphone, I'm afraid, so IT department, I'm sorry, I'm holding your lovely lavalier microphone. If you want to try and fix it, you're very welcome. Good morning. Thank you, Ian, and thank you, WCMICS, for the invitation to come and speak to this this group of people who I find very humbling to stand in front of you and discuss prostate cancer. Because, of course, some of you are my patients or you're patients at the hospital. Number one, that's always a very awesome group of people to speak to, people you've had the privilege of looking after, whether that's writing a prescription or doing surgery on or whatever. It's a great privilege and very humbling for us to be allowed to advise other patients, friends, colleagues, other people on their medical management. So I always find it very humbling to speak to a group like this. And second, of course, the topic, it's important, it's very, very close to my heart. I'm a full-time prostate cancer specialist. I'm a urologist, which means I've done all sorts of genital urinary surgery, benign, malignant kidneys, etc. But for the last 10 years, I've devoted myself completely to prostate cancer surgery from a technical point of view and research from a bigger point of view. So I'm very pleased to speak to you about some of these topics we've listed. And this one, for starters, it's clicked off. Is a huge topic. We could speak for hours about advances in diagnosis and treatment. But what we are going to speak about in short bites, because I think I find it easier to digest stuff in short bites. I hope you do too. Each of these areas under the diagnosis bit and each of these areas under treatment, I'm going to give you some take-home messages on these areas because they've all been areas of tremendous progress in the past few years. So let's first of all think about how things have changed in the past 20 years. It's quite amazing, really, for those of you who were around long enough to 20 years ago remember what prostate cancer diagnosis was like. That was it, you know. PSA testing had come in the early 1990s, which did lead to a lot of men getting diagnosed earlier, thankfully. It was the start of a whole change in the outlook for men with prostate cancer. Putting a finger in the bottom, we still do that, as some of you know, digital rectal examination. And then the way in which we would diagnose prostate cancer, as Catherine will talk to you about was very, very, blunt, to be honest, back then. A straightforward 6-core biopsy, so 6 cores up to the bottom to biopsy the prostate. We generated the Gleason score and we did some basic scans. If we fast forward 10 years, there were already, come on, mate, oh yeah, I broke this thing, I'm afraid. You're used to me breaking things around the hospital, aren't you? It's just this thing, nothing's very much. Fast forward 10 years and look how things changed. Thank you so much. Yeah, thank you. Feels good. A few things changed. We still used some of the tools, but PSA became a little bit more specific, and using the free to total ratio. Nomograms came in, which are prediction tools, so we could take a patient coming to us age 60 with a PSA of 4 and a soft feeling prostate and put it into a prediction tool, and it would give us some prediction in which way we could advise that patient about whether he might want to consider a biopsy. And the Gleason score became a little bit revised around that time, and Catherine will speak more to that, I'm sure. We still just use CT and bone scan to figure out as the cancer changed. But now, look, today, 2018, the list is expanding all the time. We still use some of the things, but I'm going to speak to you in particular about MRI scanning, transperineal biopsy, and targeted biopsy. Catherine's going to talk about pathology, which is that next box with grade groups and all that stuff. And then I'm going to focus on PET scanning, because that's been a huge revolution for us as well. So this is a normal MRI scan, just to orient you. Hands up, is that an MRI scan? This is actually my MRI scan. I do tend to overshare. And I tweeted out this MRI scan, because that's another thing I'm inclined to do, just to share it with the world and my 5,000 or 6,000 followers. So this is the bladder, which is the white bit here. We're looking from the side on here. This is the patient's spine at the back and the pubic bone at the front. So you can imagine that. And the back passage is here. This is the prostate. So when we pee, we have to pee from the bladder here down through the center of the prostate, out through the urethra. But this is the cut as though we've kind of taken it in half like that, like a guillotine. And this is the bit where we look for where cancer is. This is the back passage, and this is the prostate, central bit of the prostate. And this is a normal looking prostate. And this is an abnormal looking prostate from one of my patients recently. So what I'm about to say to you is that the paradigm has shifted very dramatically. So we no longer just have a 65-year-old patient, but that's still the average age we diagnose men, coming in the door with a PSA of 6 and maybe an abnormal rectal exam. They go straight to biopsy. Almost everybody goes straight to an MRI scan nowadays, and that's a good thing, as I'll explain in a moment. So this is an MRI scan, again, showing the same sort of view the prostate I've just shown you, except now there's a bit of a black spot there. It's not very impressive on this particular sequence of the MRI scan, but on this sequence and this sequence, because it's full of different sequences, and then on this sequence, it all adds up, and we call this a PIRADS 4 lesion. Those of you who are on this journey will recognize some of these terms. So we love things that go from 1 to 5 in medicine or in cancer in particular. So if your PIRADS score is 1 or 2, it's normal. If it's 4 or 5, it's increasingly more likely that you have significant prostate cancer, not just a little small cancer, but a proper one. The 3s, of course, sit in the middle. You have to have something to sit in the middle. So this chap underwent a biopsy, and this is another big change for those of you who've had a biopsy of your prostate. We've now, just this year, started biopsying only those bits, so maybe just 3 or 4 cores, which Catherine's happy about, less pathology specialists to look at. And we tend to, in select patients, not bother biopsying the rest of the prostate. And this leads to less complications. Just published, big trial in New England Journal of Medicine. So this patient had a transperineal, I'll come back to that, targeted biopsy. So we're targeting that little lump, and we find what we would call this in the old days, Gleason 7 prostate cancer. We now call that grade group 2, because again, we've changed the biopsy reporting system. So instead of Gleason 6, 7, 8, 9, 10, these confusing old numbers, we still talk about them, but we've rationalized them into a 5-point grade group system that Catherine will talk about. Again, 1, 2, 3, 4, 5, the lower the better. This is grade group 2, which means it's a clinically significant cancer, not as bad as a 4 or a 5. And this is his prostate after it came out. And what you see here is the cancer, which is here, the index lesion, we call it the main cancer, matches exactly where the MRI was. And of course, I've shown you a good example. They're not all quite as good as this. But a message I want you to hear about MRI scanning is it's really become frontline now for people suspected of having prostate cancer. And if you have this type of lesion or abnormality you see here, we'll do a targeted biopsy of it, which saves you having a lot of extra cores being taken from your prostate. And then we see it helps us planning nerve sparing and stuff like that, because we can see that that's the truth of the cancer. But the black spot you see here is also cancer. That's low-grade cancer, grade group 1 cancer, or Gleason 6 as we used to call it. And you don't see that on MRI. It just doesn't show up, which is a good thing. So if you come in age 65 with a PSA of 6 and your MRI is normal, it doesn't mean you don't have prostate cancer. It means you're very unlikely to have this type of prostate cancer, but you may well have this type of prostate cancer. And does it matter if we don't find that out? In other words, I say to you, I think your MRI is normal. Your likelihood of having significant prostate cancer is low, very low. Would you accept that and say, okay, I'll accept that? And a lot of people would. So this is our practice now. This is the take-home point on this. We've just published this in Nature Urology, a summary of this whole paradigm. And this is our practice, mostly around Australia, certainly here at Peter Mac and the cancer specialists. And this is a figure we've published in Nature Urology. So man suspected of having prostate cancer. PSA is up a little bit, he's in the right age. Family history maybe. Informed decision making, which means you have a chat with your GP and loved ones about whether you want to be tested or not. You have a PSA, and then you get sent to a urologist. We do an MRI scan for almost everybody, and since the 1st of July, of course, in most incidences here around Australia, it's rebatable, so you're not having to pay for the MRI anymore. Saves $400 or $500. If it's normal, like this one, we will often just do routine follow-up, keep an eye on the PSA. But we will still biopsy some normal MRIs if there are red flags. Like the PSA is going very high, there's a strong family history, we can feel a very obvious nodule, you're a BRCA2 patient, etc. Some red flags. There are red flags that exist that will make us say, let's not put all of our faith into the MRI. And then if you have an abnormal MRI, we'll do a targeted biopsy. And that is now the modern era, actually. So what has this led to? It means that less men are having biopsies. It's a good thing. Of those who are having biopsies, many are just having a targeted biopsy. And we're reserving systematic biopsy for those with red flags. So that's good in terms of less biopsies. It also means less active surveillance, potentially, because we won't find those low-grade cancers. And I'll come back to active surveillance in a moment. So if you do need a biopsy, how are we going to do the biopsy? I won't ask who's had a biopsy. Oh, many of you will volunteer. You're a very active group of consumers. People are already raising fingers. This is a headline from The Age a few years ago. This patient after a transrectal, the old-fashioned biopsy where the needle goes through the bottom into the prostate, but that's an easy route to the prostate. Sepsis, nearly lost his leg. It's not rare, unfortunately. It's not very common, but because so many biopsies get done, if 5 or 6% of patients are having sepsis in the intensive care unit, that's a significant number of people. So we stopped doing that type of biopsy very many years ago. Where I trained in London at Guy's Hospital, we were routinely not putting the needle through the rectum into the prostate. This is transrectal. We're putting the needle through the skin underneath the scrotum, which is called a transperineal biopsy. And when I took over here, we shut down transrectal biopsy. I said this is for the past already. And if you come in here and have a biopsy, you'll only have a transperineal biopsy, which means having a special bit of equipment and a short general anesthetic. That's what it looks like. I wasn't going to show you the whole gore, but this is an ultrasound of the prostate, and this is a needle coming in here. That's the needle going in. So the patient is lying on the operating table, general anesthetic, legs up in stirrups, kind of, so we can get a good access at your undercarriage, if you like. And then there's an ultrasound probe going into the rectum. The rectum's just there, and we're scanning the prostate, which is here, guiding the needle in. So that's an ultrasound-guided transperineal biopsy. And that's the way all biopsies are done around here now. And safety data is very impressive. We've published a lot of papers about it. I'm not going to drown it out. This is a paper we published in Nature Urology as well a couple of years ago, summarizing the data, saying that let's stop doing transrectal. This is the rectum here. Ultrasound probe used to go in here. Now it goes through the skin. Much safer way to do the biopsy. So safety is the main thing, of course, and the risk of sepsis is not zero. We've had one or two. But it's dramatically lower compared to firing the needle through the poo, as I keep telling people. Trans-poo biopsy, why would you do that? So transrectal ultrasound, TR is transrectal, has significant infectious complications, and these are increasing actually because of antibiotic resistance increasing, especially around Asia. And that's the problem. Drugs like ciprofloxacin, which are our mainstay of treating those types of infections, have rising rates of resistance, so we need to protect those drugs. There are strategies to reduce it, but I think the best way by far is to put the needle through the skin, not through the rectum. And we're not just outliers. We kind of were when we started doing that. There were only 2 or 3 other people around Australia interested in this, but now over 50% of all prostate biopsies in Victoria are done using a transperineal route, and that number is rising. So I think we'll look back in 20 or 30 years' time and say, what were we doing putting the needle through the poo? Because everybody will have changed. So if you're considering a biopsy or you're on active surveillance, and you're having transrectal biopsies, you should ask about transperineal biopsy. It's no longer rare. And we'll have time to stop and have a little chat at the end. So maybe we'll stop after the diagnosis bit in 2 or 3 minutes and have a chat. And the other big thing about diagnosis is PET imaging. And some of you will have had a PET scan, others will have read about this because it's been quite topical. Here's a patient of ours who has had a bone scan, which is the traditional way of trying to see whether there's cancer in the bones in patients with prostate cancer. And this patient was referred into us with this bone scan. And he's got 5 metastases, I think. So there's one there in the rib, there's another one there, and there's another one there, another one there in the sacrum. And he was referred into us for a clinical trial where we were putting stereotactic radiation into men with low volume, or oligometastatic, we call it, prostate cancer, which had to less than 5 sites of disease. We published the paper actually just a month or 2 ago, the PopStar study in European Urology. But we recognize that these 40-year-old technologies like bone scanning are quite limited in picking up, these types of cancers. So then we started doing PET scans on these patients, and this is the PET scan of the same patient we've just shown you actually. And all those black bits are cancer, except there for the kidneys. So his true situation with metastatic burden is dramatically different. So if we were only going to zap these few little things on a clinical trial, obviously all the other stuff will be flourishing. And these are very typical pictures for us, these types of dramatic truth, if you like, of what's going on. And there's a few different types of PET scan, PET tracers you can use. The one that we use for breast and melanoma, ovarian, colorectal is FDG, common tracer. But PSMA, prostate-specific membrane antigen, is the new kid on the block, which we started using here just over 4 years ago, August 2014, first in Australia, in the old building at Petermac. And now it's become very popularized. We've published a lot of papers about this, and we're running a number of clinical trials. And what we're showing is that this is a much better way of staging your prostate cancer, not just these dramatic, very metastatic situations, which I'll come back to in a minute because they're important for other reasons. But what about the patient who you're thinking of doing a prostatectomy or radiation on, that they've got a high ISUP score and PSA is 30 and your CT scan's normal, but you're thinking, these are the sorts of patients that come back a year later with secondaries. So do they have secondaries at the start? And that's where the PET scan can sometimes help, and we have a clinical trial for that reason. Here's a 46-year-old patient from Darwin who was referred down to us in February with very nasty prostate cancer. PSA 14, clinically T3, PIRADS 5, which is the MRI scan, and grade group 5, which we would call Gleason 9 in the old days. And we had enrolled him in our 46 in one of our randomized trials of PET imaging called ProPSMA, in which you get both a CT and a bone scan, and you also get a PSMA PET scan. And this is his PET scan, unfortunately, showing widespread secondaries. All those lumps there are secondaries. These are the kidneys, which are normal. And as we scroll down, we're coming from the kidneys down towards the pelvis. These are normal. That's just a bit of urine in the ureter as we come down. But that's cancer there, high up in the abdomen, beside the aorta. There's the aorta and the vena cava. There's more lymph nodes. These are all perioptic lymph nodes. He's got no cancer in his bones, but lots of cancer in his lymph nodes, big lymph nodes, invisible on CT. And we've biopsied loads of these in the past 4 years. We know this is cancer. So it's a big change because these are again big lymph nodes as we get down into the pelvis here. These are the hips, more lymph nodes here. This is bladder beginning to appear here. More lymph nodes, I think there are 20 or 30 of them. And this is his prostate cancer, lighting up at the primary. So quite a big difference, yeah. Normal CT, it's just shades of gray here, and then you see the truth over here on this. So a few questions about that I won't go into for you, but we're trying to still digest, wow, right, this is really telling us what's going on with these cancers, so what are we going to do? How are we going to reconcile the fact that a 46-year-old otherwise would have been offered radiation or surgery or both, and now we know he's got secondaries up to here, so what are we going to do? Are we going to throw the baby out with the bathwater? So decision impact is what we call it when you actually have a much better diagnostic tool. How does it impact on our decisions or advice to patients? And that's a key, a primary endpoint in the study, actually, this $1 million PET imaging study that we're running. Take home message, yes, PSMA PET CT, definitely superior to the conventional scans and lots of trials underway. So maybe I'll stop for a minute and see, does anyone want to ask me any questions about these topics, MRI scanning, prostate biopsy, or PET imaging?
Just trying to work out why they're still doing rectal sampling. Why don't all change? Is it more difficult? Is it just resistance from experience, or what?
It kind of seems bleeding obvious, doesn't it? Why would you do that? So here are the barriers to it. First of all, you require a general anaesthetic, so that means coming into one of our operating theatres, whereas a lot of transrectal biopsies, especially in the US, are literally done in the clinic. Patient rolls over on the side and local anaesthetic up through the bottom, but no sedation. So that's very quick and cheap, especially in the US where money counts for a lot of stuff. So if you're doing a lot of transrectal biopsies on a list in a public hospital, maybe 8 or 9 in a morning session, and you have to bring them instead to the operating theatre and have a general anaesthetic, that's a problem for the health system because the reimbursement is the same. You get paid a very small amount of money to do these types of procedures in the hospital. And second, there's a bit of specialised equipment which we use for brachytherapy, for types of radiotherapy. But what's ended up happening now is even centres like Epworth, Richmond, for example, that doesn't do brachytherapy, but does a lot of prostate biopsies. They've now invested in 2 sets of this equipment because they've listened to the urologist saying, we don't want to put needles through the bottom anymore, and most biopsies in places like Epworth are now done transperineal. But there are little things that are progressing to take down even those barriers. So there's a new little bit of equipment, much smaller, cheaper, disposable, that would allow a centre that doesn't have this type of equipment to do it. So that's the equipment issue. And likewise with that, it's also been shown to be possible to do this under local anaesthetic. Although we're quick at doing these, so when I get my one done, it'll be a general anaesthetic.
So if you went to a urologist and he was doing it the old way through the rectum, you would have second thoughts about the urologist?
Yeah, but it's important to state that that's been the standard over the years, and there are some of those barriers. Unfortunately, that means that urologist will be definitely aware of the transperineal route, but it may not be possible in his or her situation to offer a transperineal biopsy at the moment. And in the US, a very small number currently are done using this approach because they just won't get reimbursed for it. But patients are listening, So when the patient comes in and says, well, I've read about this, or I've seen a bit in the age about the prostate biopsy sepsis, or my brother-in-law's had sepsis, what about having it the other way through the skin? Or could I please refer me on? It's no longer something that only we can do. As I say, over half of all prostate biopsies, public and private, in Victoria, we just published a paper from the Victorian Registry, are done transperineal, which I think is great. And in the UK, same thing, over half of biopsies transperineal. And we will look back in 20 or 30 years, and I stood up at a meeting in the US last month and said this, we'll look back at you'll all look back and go, what were we thinking putting the needle through the rectum? Why would you? It's convenient for sure.
Some urologists will do a suppository before the actual insertion. Is that just a bit of depends how well the urologist is up to speed on that?
It doesn't help with sepsis, but it just helps with the vision, because sometimes when you put a transrectal probe in, if there's a lot of feces, it'll decrease the view. We have the same potential issue with the transperineal. But the other strategies that have been tried through the rectum to try and reduce the sepsis are taking a rectal swab, but you have to do it a week before, and look for these quinolone-resistant bacteria. So if you take random rectal swabs around Australia of men in their 40s, 50s or 60s and send it off for analysis, what percentage of men do you think have E. coli resistant to Cipro in the rectum? 20%. Yeah, it's about 20% of people in general. So these bugs live there, and the quinolone resistance is just now in the water. And it's driven out of overuse of antibiotics, especially in Southeast Asia. It's in the food chains. It's because in Southeast Asia, a big survey from Bloomberg, or big investigation, showed that the chicken farming done in India relies on high-dose ciproxan in the feed to make up for poor sanitary conditions. It was quite a big story when it came out 3 years ago. So we have to be aware that there are factors that mean The WHO, I referred to it in that Nature paper, the WHO last year said we are looking down the barrel of a post-antibiotic era if we're not careful with antibiotics. So I think as stewards, just from an antibiotic stewardship point of view, as people who have the authority to write scripts, we need to do the right thing. And so for these, we just give a single dose intravenous of not ciprofloxacin, of a different antibiotic, 1 dose. Whereas if you have a transrectal biopsy, you have 3 days of antibiotics, including starting before the procedures. I'll move on to treatment. And so again, I could have talked about other stuff, genomics and all this as well, but yes, 1 minute for the whole thing. I thought we were going to 10. Huh? 10 minutes, good. And this section's even bigger. What are we going to talk about in this? But I'm going to give you take-home messages on 3 of these areas because they're very, very exciting and important. Active surveillance, of course. I'm sure some of you in the room are on active surveillance because we have thousands of men in Victoria on active surveillance. We published data on 1,600 men just a few months ago on active surveillance. And the principles are that you've got a patient diagnosed with prostate cancer, and that by avoiding intervention and the side effects of intervention, which means treatment, surgery, radiation, whatever, that you're going to have that benefit of avoiding treatment, but you're not going to have a compromised outcome from a cancer point of view. In other words, we're telling you you've got cancer, and it's okay not to have treatment. And people will put up their hands and go, but I don't want to die of prostate cancer. I've got a friend of mine did that, it's a very bad thing. So we have to be able to assure people that avoiding treatment is not going to compromise the cancer outcome. That's what active surveillance is. And these goals are really readily met, and the data shows us that. Utilization is increasing. We published this paper in 2015, showing from the Victorian Cancer Registry that rates of surveillance, which are the blue bars, were rising in these years as people became aware that surveillance was an okay thing to do. And we've updated it just a couple of months ago now with over 3,000 patients. And so the rates are increasing. So what we see is that low-risk prostate cancer, which is predominantly men with grade group 1, or Gleason 6 as we call it, 55% of them are on surveillance. And in certain environments and centres, the numbers are higher, like 80%, 85%. It'll never be 100% because some men with low-risk cancer, we're very cautious about surveillance. So if you're 45, you're bracket 2, everyone in your family's died of prostate cancer, you may not be accepting of it, and we're very nervous about it. But the majority of men, 60, 70% of men on low-risk cancer are on surveillance. 15% of even slightly higher risk patients will opt for surveillance. And Penny will talk about that when she talks about decision impact. So this is good, and this is what I say to all my active surveillance patients. They'll say, well, what's the likelihood I'm going to need treatment? And we publish this data. At 1 year, about 17 or 18% of patients will change from surveillance into treatment. And when you follow it out for 5 years, that number rises up to about 25 or 30%. And the other 70 or 75% stay on surveillance, avoid treatment, not going to die of prostate cancer. And the ones who get intervention, likewise, their prostate cancer survival is the same as if they had their surgery at the start or their radiation. So surveillance is very good. It's a great option for people. We've become very comfortable with it. I think patients have become comfortable with it. But Penny Schofield will talk about that in her talk about decision support for couples in this situation. Safety data is good. People don't tend to die. But you do have to be careful with the old Gleason pattern 4, which is Gleason 7 or 8 and above, or ISOP grade group 2. Data showing that of the few people who die, these are men on surveillance, not dying of prostate cancer, but the few that die are the ones who are intermediate risk. So we don't routinely recommend surveillance for men if they've got intermediate risk prostate cancer, which means Gleason 7 or above. So the take-home message is yes, active surveillance. Australia is one of the countries around the world that have been leaders in active surveillance, because urologists in this country have heard that message, and we believe it's right that you can avoid treatment if you've got certain characteristics. And this is one of the reasons why second opinions are very important, and almost all our patients are second opinions here or in our private practices, and it's because the word has got out through consumers. It's a good idea to get a second opinion, and we turn people routinely from I think you should have surgery into I think you should have surveillance all the time, every day almost. So get a second opinion, and surveillance is a very good thing. And it has certainly mitigated all the people who are naysayers on the whole prostate cancer detection business, the whole screening type argument will say, no, it leads to too many men being diagnosed with low-risk cancer, and the urologists and radiation oncologists are going to treat all those men. No, we're not actually. The data shows that surveillance is the way you mitigate the fact that lots of people used to get diagnosed with low-risk cancer. And the other thing is that MRI scanning means we won't be diagnosing many of these men with low-risk cancer because you just don't see them on an MRI scan. So you never make the diagnosis in the first place, and that's probably further benefit of surveillance. How do we do it? Well, there's lots of protocols. We've published lots of data about this in one of our papers, so I won't go into that, but the protocols are well described, and I'll summarize it here. Most protocols, like the academic ones, will say only ISOC grade group 1. I've mentioned that some people with higher grade groups will be on surveillance. That's mostly because the patients have decided to take a risk on it, but the protocols that have proved surveillance is safe have been really restricted to low-risk prostate cancer. If your Gleason score or your ISOC grade changes, then that's the trigger, the main trigger really, that you go from surveillance into treatment. And this is how we do it, a PSA every 6 or 12 months. We repeat your biopsy about 1 year after your first diagnosis, and then every 2 or 3 years afterwards. And even that's decreasing because we're using MRI a lot more. And again, since the 1st of July, not just new patients thought that they might have prostate cancer, they get a free MRI scan, but patients on surveillance also get a funded MRI scan every 3 years in Australia. And again, Australia leading the way here. We're one of the very, very few countries in the world where MR is supported for this indication, which is a great thing. And will probably mean less biopsies, I think, as well. This is a bit about sepsis, I'm going to skip past that. So take-home message is, yes, AS is safe. MRI scanning and transperineal biopsy makes us know that we're doing it right. But we do have some concerns, and this is a headline from the ABC a couple of months ago after a paper we published in the MJA. Norman Swan saying that men with slow growing prostate cancer aren't being properly monitored. And so this got a lot of headlines when we published this paper. And the reason is we published data on 1,600 men on active surveillance who'd been followed up for 3 years or more. So we've been following these men for a while. Victorian patients all around Victoria, public and private. And what we concluded was that 3/4 of men on surveillance in Victoria, which could be people like you in the room, are not being adequately monitored, partly because of clinicians or hospital faults, partly because of patient fault. And we set the bar pretty low. You know, you had over a 2-year period following diagnosis, we said you should have 3 PSAs, you should have at least 1 biopsy. And only 25% of people are having that. So we were glad we got the publicity because we need to get the message out there that if you're on surveillance, you know, you do actually need to do a little bit of surveillance. A couple of minutes left. Surgery, I'm only going to show you one thing about that. Some of you have had surgery. I've seen patients in the room already that have robot scars on them. This is our robot downstairs. As many of you know, Peter Max had a long history of innovation in surgery and radiation. And this is the Da Vinci Xi robot that we bought last year to replace the previous one. Fabulous bit of kit. This is a surgeon looking in here. I'm actually on the other machine controlling it, and there's one of my senior fellows looking in here. There's a little touchpad that switches controls back and forth. The patient is here, and this is the robot over the top of the patient. It's gigantic if you've ever seen it, but the holes that go into you are the size of my little finger. 4 holes for the robot and 2 additional ones. So the patient's head is under here, and then this giant machine has these little holes going inside. And we control it from over here. We have an amazing view inside the abdomen to do this type of surgery. So I suppose that's been one of the big innovations, but what it's also meant is that places like Peter Mac having it means that it's no longer something you can only get in the private sector or that you have to pay big fees for, because places like Peter Mac will always offer the latest technologies at no cost to the patient, thanks to the Peter Mac Foundation being so generous, the donors to the Peter Mac Foundation being so generous, I should say. And I'm not going to say much more about that, except that it's clearly not about the machine, and most of you know that. I love this quote, "A fool with a tool is still a fool." So just because someone has a flash bit of kit or a laser or a linear accelerator or a robot doesn't mean that you're going to have some sort of guaranteed outcome. And everybody knows that surgeon expertise and the procedure volume is much more important. So if we have people coming for a second opinion who come from a very experienced open surgeon, he or she is highly trained in open prostate cancer surgery, and they do a lot of cases, maybe 50, 60, 100 cases a year. Or they can go to a less experienced surgeon who has access to a robot who does 1 of these a month. They're always going to do better with the open surgeon. But the reality nowadays is, of course, the highest volume specialist cancer surgeons are all using the robot, bar 1 or 2 still around the city. And we have the highest volume prostatectomy problem. God, I must have been double reading an email about our volume actually when I wrote that. So we have a huge volume, and that's purely because of the profile of Peter Mac. We take patients from all over the country, of course, as well. We don't have a catchment area per se. And our wait list for prostatectomy is 3 months, just over 3 months at the moment, which is okay. Most prostate cancer is no problem waiting 3 months. Finally, PSMA theranostic. So I've mentioned to you that PSMA shows that dramatic patient with all the bone metastases who definitely is going to die of their prostate cancer at some stage. But a lot of stuff has happened in the past few years to improve outcomes for those patients. So one of the most exciting things is PSMA-based therapy. So then this is again a different patient, adrenal metastases as well as all these bone metastases, has failed all treatments, docetaxel, enzalutamide, abiraterone, everything. And what we do now is we combine the PET imaging molecule with some active therapy, and the one we use around here is lutetium-177. And we published a huge, we published a huge paper about this in Lancet Oncology a few weeks ago, which got a lot of publicity. It's partly our own fault for making these flashy videos. I don't know where, this one came from PCFA, we should acknowledge PCFA, when they were funding a multi-million-dollar trial, but it makes this therapy, there's Michael Hoffman who leads the trial here, and very alluring for patients, because you have these types of amazing scans full of secondaries, and then we give patients PSMA lutetium therapy. That's one of our patients here on the trial, and the scans just turn normal, and people are very attracted to this. And this is what happens to the PSAs we published in the trial. Bang! Amazing. And these are all patients with 3 months to live. These are absolutely no options left. Published in one of the largest cancer journals in the world, so it got a lot of publicity. And now we're running multiple other PSMA trials on this. So here are some of our patients, just to show you what happens to them. So here, PSA is nearly 1,000, failed everything. All the abnormalities become normal. The PSA is 7, PSA is 1,000, look at all the metastases, now it's 28. And the therapy is very well tolerated. We give it on level 5, 2 stories below here, and all the scans start turning normal. So again, PSA, it's getting up to the thousands. They've had all the treatments, bang, bang, and we can give more lutetium. We can give one cycle, another cycle, another cycle, another cycle. Everyone's going to die if you come into the study with this type. We're all going to die of something, and if you've got this type of prostate cancer, you will die eventually of your prostate cancer, probably. But you're going to get what you see, almost 3 years extra life out of it with some of these amazing treatments. So that's very, very exciting. It's one of the most exciting developments I've seen in recent years, and much of it's led from Australia, from this building in particular. Millions and millions of dollars worth of trials now running in lutetium PSMA, coordinated from here and now running around the country as well. And I'll acknowledge the teams who run that. This is GU Oncology, our team here, including Catherine, and this is the nuclear medicine department, Professor Hicks and Hoffman and co downstairs will lead a lot of these trials. And I'll leave that up if we have time for a question, because as a consumer group, the other thing I wanted to say to you was we're always looking for consumers to work with. And a lot of the grants that we run in here, people like Ian are very good at giving their time to sit on panels with us, because we so value having consumer perspective on the work we do. And not just that, but the grant funding bodies value it greatly as well. They want to see clinicians and scientists and researchers like us buddying up very, very closely with consumers, so we're asking the right questions and we're designing trials that are palatable and interesting to patients. So I encourage any of you to send me an email if you've got questions, but especially if you're a consumer being involved with us on this journey, and certainly even identifying yourself. A lot of it can be off-label, if you like, just contributing to committees, but we're always looking for you. And I thank you very much again for the invitation and for allowing me to speak to you and to look after some of you as well. Thank you very much.
Quick
Any
question.
questions?
Why can't we just dissect that part of the prostate that's got cancer out and leave the rest rather than taking it all out? It's just something that...
Yeah, totally right. And I get asked the question all the time. And we do that with other bits of the body, of course, the liver, the breasts, the kidneys for us as urologists. The prostate just doesn't lend itself to it. It's very difficult to identify these tumours within the prostate as one issue. And also it tends to be multifocal in 30% of patients, as Catherine will attest to. We often see cancer in different parts of the prostate after we take it out. But instead of cutting them up, the big interest is in a thing called focal therapy, where you leave the prostate in there and then we aim for where we think it is, the cancer is, like I showed you on the earlier patient with the MRI scan. And then using either radiation therapy or new ablative techniques like ultrasound or nanoknife, or there's a bunch of different things we can do to try and ablate just that bit of the prostate, and that box is called focal therapy. We're very interested in it, but it's an evolving area. And the problem with focal therapy is it used to be for lower risk patients, but now those patients we know don't need treatment, just put them on surveillance. And the higher risk patients are the ones that actually probably need more aggressive treatment. So we're struggling with where focal therapy will fit. But it would never be surgery, it's going to be some sort of ablation.
Another question?
Oh, I've got a question about active surveillance. You mentioned that there was potentially underactive surveillance.
Yes.
Would it make sense to have MRIs or PET scans on an annual basis? What can be done to increase the activeness?
Yes, that's very good. Inactive surveillance is what we call it. So that's certainly one consideration, is if it was more attractive or easier for patients to get their surveillance, would they do it? But we think there's a fundamental problem. In fact, out of this project, there's now a narrative project where we're ringing hundreds of these patients to say, we note you haven't had any surveillance for years. Why is that? And the answers are very interesting. Sometimes they say it's too expensive. They'll say, I'm in private practice, it costs me $300 to see the guy, it's cost me $500 for an MRI scan, because that's what it did cost, etc., etc. So we're identifying the barriers, and out of that will come a project to hopefully reduce the inactive surveillance. And to be aimed both at clinician and health sector level and also patient level. We found also when we looked at public and private that it was worse in the public system. So we think private practice, maybe they've got better systems where we recall patients for their appointments, maybe we lose patients easier. But there are definitely patient factors. There are men out there who they came back for the one biopsy or didn't come back for it, and the message they thought, instead of saying you've got low risk cancer at low risk of progression but need some surveillance, when the bloke goes home to his wife, he says, great news, it's not cancer. I don't need to go back. Which is why so many partners come to consultations, which is a great thing, You don't trust him, do you? Yes, I don't trust him. So we have to work on everyone in the journey.
Last question.
If you've had surgery and then the cancer has returned and you have targeted radiation a few times, rather than keep on having that targeted radiation, would you recommend perhaps an early intervention with this new ESNA?
Very good. So having recurrence after surgery or radiation is not rare. Over a 5-year period, between 25 and 40% of patients will have recurrence of their PSA. Many of those men don't need treatment, by the way. We can often monitor them. But of those in whom we see there's a lymph node or there's a bone or something, yes, targeted radiation, stereotactic radiation, which can be repeated, is one option. But we've just published a large prospective study of that, showing, number one, it's safe. You don't seem to burn up on the inside. But number two, almost everybody will recur within a couple of years. So there's a question about, would you be better off just going forward with maybe hormone therapy plus minus chemotherapy plus minus lutetium in the first place, instead of just bzz with the radiation. So it's an ongoing discussion. I suppose the message I'll give you is that there are loads of options apart from lutetium. And if you've had some radiation to recurrences, what we advise patients is to then go on to systemic treatment, not just ablative local treatment, but systemic treatment, which means in men, unfortunately, some sort of hormone therapy plus something in addition on top of it. And there are lots of clinical trials in that area. So again, we get a lot of patients coming into us to say, I've been in exactly that situation. You guys didn't do the original surgery or whatever, but they feel like they want to explore these options. Explore the options.
Please join me in thanking Declan.
Thank you very much.
Thank you so much for coming today and being part of this event. This is a small token of appreciation from the...
Thank you, Wick.
Thank you.
Thank you very much.
Well, thanks, Declan. As somebody who did have it through the backside and got away with it, I'm very pleased that I didn't know quite as much about the percentage problem at the time. And I wish I'd known about the robotic surgery here, because it wouldn't pay me 20 grand. Anyway, our next speaker is Understanding Prostate Cancer Pathology, and our speaker is Dr. Catherine Mitchell. Catherine is a pathologist at the Peter MacCallum Cancer Centre, as Declan already mentioned. She now works in the field of surgical or tissue pathology with an interest in urological pathology, and regularly reviews biopsies from men with prostate cancer and is involved in research around prostate cancer. Please welcome Dr. Catherine Mitchell.
Thank you very much, Ian, and thank you very much, WCMICS, for the invitation, and thank you to all of you. I want to reiterate what Declan just said. You know, I'm a pathologist, I don't often get to see the people at the end of my diagnoses, but I really consider it a privilege to be here speaking with you. And look, a privilege to do the job that I do. So just to explain what that job is, I'm a pathologist, so I am a medically qualified doctor, but instead of seeing patients, I look at bits of tissue that have come from patients. So if you have a core biopsy or if you have a lump of a tumour resected, then that comes down to the pathology lab, and I'm the person who looks at it under the microscope. And our job is to make a diagnosis and try and tell you as much as we can about your tumour, so that you can then choose the best treatment option and have the best idea about what that tumour is going to mean for the rest of your life. So, what we're talking about today is a little bit about prostate cancer pathology. So I thought I'd briefly touch on what the normal prostate gland looks like, and then talk about how we diagnose prostate cancer, and then try and talk a little bit about what goes in a prostate cancer report, and hopefully explain that to you a little bit. And I think we've got some time at the end for questions, so I'm more than happy to hear questions or comments. Declan showed a MRI image of this. This is sort of what it looks like in an anatomy textbook. So this is a slice cut through the body this way, so you sort of cut in half long ways. So this is sort of looking at the midline of the body. And the prostate gland is this little bit here. They say it's about the size of a walnut, although it can be a bit bigger than that. And it sits behind the pubic bone there, and then in front of the rectum here, and then below the bladder there. And there's a tube called the urethra, which runs from the bladder straight through the prostate gland. So, you know, it's right there in the middle of a lot of other things. And this is what the prostate gland looks like under the microscope. So these things here are the glands, and then the pink stuff in between is stroma. And this is on higher magnification. So these are the normal cells of the prostate gland. These are the cells that secrete PSA. So this is what we hope to see when we look at a prostate biopsy. So what does prostate cancer mean? Now, look, I've put this picture up here. So this is the WHO is the World Health Organization. So this is their classification of all tumours that can occur in the prostate. And I don't want to scare you, I just wanted to make the point that there's a whole heap of tumours that can occur in the prostate gland. So, you know, some people may get weird and wonderful diagnoses. There are some really rare tumours that can occur. So there's a big long list of things that can occur. The ones that we see most commonly, and the ones that we've really been talking about today, is adenocarcinoma, which comes into the group of epithelial tumours. So that means it's a tumour of the epithelium of the prostate gland. And most of those are adenocarcinomas. And in fact, most of them are what we call here acinar adenocarcinomas. Although more rarely we get a tumour type called a ductal adenocarcinoma, and some of you might have heard that. So really what we're talking about today is acinar adenocarcinoma or adenocarcinoma. So when I say prostate cancer, I'm really talking about adenocarcinoma, which is the most common that we see. And this is what it looks like under the microscope. So we've still got those same glands that we saw in the benign prostate gland, but here they're growing in an uncontrolled fashion. So there's too many of them, the cells are a bit too big, and the growth is uncontrolled. So so this is an acinar adenocarcinoma. In this one, the glands look a little bit different, and this is what we call a ductal adenocarcinoma. So your first introduction to a pathologist or to pathology in your prostate cancer journey will usually be through a PSA, and I just wanted to briefly mention that. So it stands for prostate-specific antigen, and PSA is a protein that's produced by the epithelial cells of the prostate gland, and it's produced by normal cells in the prostate gland. So everyone who's got prostate gland will be producing PSA. The issue is that in people with prostate cancer, you'll produce more PSA, and so the PSA level will be increased. And because cancers have that phenomenon of uncontrolled growth, they just keep growing, keep growing, keep growing, then the PSA level will continue to rise. So that's what we're looking for with PSA. We're looking for a level that continues to rise. The problem is that not all elevated PSAs mean prostate cancer. So other things that make prostate glands more active can also give you an elevated PSA. So prostatitis, which is inflammation of the prostate gland, or BPH, or benign prostatic hypertrophy, which is something that we see with aging where the gland just becomes bigger, can also give you an elevated PSA. So as I said, with prostate cancer, it's that continued growth going up that is the worrying factor. But as Declan said, if you've had an elevated PSA and maybe a digital rectal examination, and then maybe you've gone on and had an MRI and they might have found a PIRADS 4 or 5 lesion, and so the surgeon sits you down and says you need to have a biopsy. Look, this is what a prostate biopsy looks like from my perspective. So what the surgeon, or sometimes a radiologist if it's transrectal, does is take these little slender cores of prostate tissue out of your prostate gland. So these are all from one patient. So this is a patient who's had sort of whole gland sampling. And the reason, certainly in the past, and still sometimes today, we do that is because, you know, the prostate gland might be sort of 4 centimetres by 3 centimetres by 3 centimetres, and the tumour might only be 1 by 1 by 1 centimetre. So if you're trying to find that small tumour in that big gland, you sort of want to sample different areas to make sure that you've increased your chance of finding the tumour if it is there. The MRI scanning is changing that a little bit, or the PSMA PET too. So if we know that the tumour's in a particular area, then we can take targeted biopsies from that area, and you might only need to take maybe just 4 cores to sort of feel like you've adequately sampled the bit that you're worried about. And this is what a prostate biopsy looks like under the microscope. So we see a core of tissue, and in this case there is prostate cancer. So there are way too many glands and they are infiltrating through, and so this is a patient with prostate cancer. That's what it looks like. So the next thing I wanted to touch on is what information will I put in my report to the surgeon. The most important thing is making a diagnosis of prostate cancer. So is there prostate cancer there or is there not? So that's the most important thing. But having said that there is prostate cancer present, there's still a lot of information that we can give. So one of the things that we look for is what's the extent of tumour. So we've only got those cores, we've only got those tiny bits of tissue, but we can still say, I don't know, there were 10 cores taken and 5 of them had cancer in, or 10 of them had cancer, or only 1 of them had cancer. And that gives the surgeon an idea about the extent of involvement of the prostate gland. And I guess the concordance isn't perfect, but in general, a smaller tumour has a better outcome than a bigger tumour. So extent either by the number of cores or the length of tumour within the cores is one way of us signalling to the surgeon, giving them some more information about the tumour. And the second thing that we look at is grade. And what we mean there is it a low-grade tumour that is well differentiated, or is it a, time-wise, I need to, yeah, okay, I need to get a move on. Or is it a high-grade tumour? So a low-grade tumour, a well-differentiated tumour, is likely to do better, and a high-grade, poorly differentiated tumour is likely to do worse. So Gleason scoring is named after a pathologist named Donald Gleason. And in the 1960s, he drew all these beautiful pictures of what prostate cancer looks like under the microscope. He sort of, he drew what the shape of the glands were. And he said, if your glands look like this, I'm going to call it pattern 1. This is pattern 2, pattern 3, pattern 4, and pattern 5. And these are the ones that do well, and these are the ones that do badly. But the problem is that not all cancers look the same throughout the whole tumour. So then he said, well, that's fine. If most of it looks like this and a smaller bit looks like that, I'm going to call it 3 plus 4, add them together, that's 7. So this was in the 1960s, and that's been tinkered with over time. And so this is the diagram that we use currently. So it's changed a bit, but the essential principle is the same. So that means that you end up with a whole heap of options. You can have anything from Gleason score 2 all the way down to 10. But what we know is that patterns 1 and 2 are really not diagnosed on biopsy. Most of the things that were called pattern 1 probably aren't even cancers, and distinguishing pattern 2 from pattern 3 on a biopsy really isn't possible. So in essence then, we've really only got patterns 6 down to 10, Gleason score 6 down to 10. And so then you're saying to a patient, well, you've got the best tumour that you could possibly hope to have. We think you can have active surveillance, but I'm calling it 6 out of 10. And it was thought that that was confusing. So that's why the concept of grade groups was introduced. So we take those Gleason score 3 plus 3 equals 6, and we call them now grade group 1, because that's the best prognosis, best differentiated tumours. And then it goes up to 2, 3, 4 to 5, where it's at the worst end of the spectrum. So having had a biopsy, some people will go into active surveillance, some may have radiation therapy, some may have hormonal therapy or chemotherapy, but some people will end up having their prostate gland removed, and we call that a radical prostatectomy. And at the PMF, they're often done with the help of the robot. And this is what I see at the end of that. This is a prostate gland with seminal vesicles. And we cut that into slices, and then we look at those slices under the microscope. And the cancer in this case is this little bit up here. Time? Okay. I was pretty close to being finished anyway, so I was just going to say the information in the report is essentially the same as in the biopsy. We give a diagnosis, we talk about the grade, we talk about the extent of the tumour, and then the only thing that's different in a resection is margin, so has the tumour all been removed or not. And my one hope for the future was molecular pathology, which doesn't have a big role in prostate cancer at the moment, but I think in the future, so I've been talking about looking at cells. Molecular pathology looks at inside the cells at the DNA or the RNA or the protein expression. And what we hope in the future is that we'll be able to use that to give us more information about how your tumour will behave, but also about what treatment is going to be best for it. If anyone does have questions or comments, I'm happy to. Yes.
Okay, question.
Catherine, thank you very much for that presentation. I just had one question, which is the precision of the interface between two adjoining ratings. I remember back when Stephen Strum, who was an early guru of prostate cancer in the US, made a big feature of the fact that you're talking about a 50-50 or a 45-55 or whatever between Gleason 3 and Gleason 4. And I'm just wondering if how you address that rather imprecise, apparently imprecise percentage as to whether it is a 3 or a 4 or in the new scheme.
Look, you've hit the nail on the head. That's one of the biggest problems that we have. So, you know, for most of the time you look at it and go, that's clearly Gleason 3, and then this is clearly Gleason pattern 4. But then there are cases where you sort of go, oh gosh, there's a couple of glands, is that enough to call it pattern 4? Knowing that if I do that, that will change the diagnosis from Gleason score 3 plus 3 equals 6 grade group 1, active surveillance is possible, to Gleason score 3 plus 4 equals 7 grade group 2, active surveillance can still be done, but is not quite as strongly recommended. So that's absolutely the issue. And look, we are only human, we do our best. So the solution that we have here in the department, and I think is used around, is to show those cases around and get a couple of opinions from different pathologists. And so we try and say, well, look, it's not just one person, it's a group of people have looked at it and we all feel the same, and that's how we do it. And the other way we do it is, as pathologists, we go to meetings where we kind of compare my threshold for calling pattern 4 to someone else's threshold, so that I'm sort of constantly getting re-educated to make sure that the way I'm practicing is in line with international standards. So yeah, one big cut-off point is there any pattern 4 or not, because that's a big cut-off point. And then the next one is, if in the core biopsy I can see pattern 3 and pattern 4, and my question is, do I call, is it, if it's about 50-50, is it 3 plus 4 equals 7, grey group 2, or is it 4 plus 3 equals 7, grey group 3, which can then change things. So again, it's the same thing, we would take it to others. But yeah, there is a degree of subjectivity in that.
Another question over here.
Once the cancer has got beyond the prostate, is there a role for pathology then?
Yeah, look, our role is lesser then. We do, some patients will have, at the time of their radical prostatectomy, if a higher grade tumour is suspected, they may have their lymph nodes removed at the same time, and so we will then look at the lymph nodes to see whether the tumour is spread to the lymph node. And the only other role for biopsies down the track is if there is tumour away from the prostate gland and there's some question as to whether it's prostate cancer in a lymph node or in bone or in liver, or whether it's some other sort of tumour. The PSMA PET scan that Declan showed can be useful, but there's a small proportion of tumours that don't express PSMA PET, so biopsy sometimes has a role in that. And also, in confirming that it is prostate cancer at that distant site.
I'd like to ask when you started, you mentioned there are several different types of cancers that can be in the prostate. I've had my prostate removed, and when I got the pathology report back, it showed 2 different types of cancer, and one was a much more aggressive type cancer, as it was described, than the lesser grade one that was there. My urologist told me that because of where that aggressive type cancer was in the prostate, is there any way to, or how do you detect that when you're doing a pathology report?
Yeah, so look, certainly that's the point of doing a radical prostatectomy or some other local therapy. You're trying to remove the tumour while it is confined to the prostate gland. So even if it is an aggressive tumour, it hasn't had a chance to spread, and so you're cured. The things we look for that might give us a clue that it might have spread, or at least have the potential to spread, we look for things like whether it's invading into blood vessels. So we call that, you might have seen LVI or lymphovascular space invasion, and what that means is that the tumour has got into the blood vessels, and if it's in the blood vessels it can then circulate and it can spread to lymph nodes or to other sites. So that's one of the things we look for. Perineural invasion is the other thing, so that means growing around nerves. So again, that's a way that prostate cancers can spread. That tends to be not distantly sort of around the prostate, but it can still spread beyond the prostate. So even though the margins of the excision look clear, so that the surgeon has got the whole main tumour out, there can be these little microscopic foci that have already spread. So that's what we look for to try and give a clue as to that.
Thank you.
Thank you very much.
The presentation is on treatment decision support. Dr. Penelope Schofield was the Director and Scientific Director of the Department of Cancer Experiences Research, PETA-MAC, for 15 years before becoming Professor of Health Psychology at Swinburne in March 2015. She still maintains her research team at PETA-MAC as Head of Behavioural Science. She has nearly 30 years of experience in behavioural psychology, psychosocial quality of life and supported care research in cancer, particularly randomised controlled trials. Please welcome Dr. Penelope Schofield.
Thank you very much, and I'm sorry to disrupt the program like this. It really is a great pleasure to come here and talk to you about one of my favourite topics, which is decision making and really delivering more information and power to the consumer so you can make the right decisions for you about your body according to your values. And in fact, I really have to point out one particular favourite man of mine in the room, who is Alan White here, in the very loud shirt. He always wears a Hawaiian shirt. But I'm going to talk about a journey that really Alan and I have been on together for the last, is it 6 years, Alan? I think it's 6 years. So the partnerships that really Declan was talking about, I think that this is something that we find profoundly useful, and particularly when you're actually talking about consumers' experiences and helping people who have been diagnosed with cancer understand their disease, get the support they need, and help them make the decisions that actually aligns with their life and their values. So this is a brief overview. And as we all know, decisions can be very difficult. This man's been sent to the grocers to buy some lettuce. No doubt his wife has sent him off and said, "Can you go and buy some lettuce for tonight's dinner?" And he is overwhelmed. This, by the way, is why mobile phones were invented, so that husbands can pick up the mobile phone and say, "Darling, what sort of lettuce did you want me to buy? There's a heap of them here." Certainly that's why my husband uses mobile phones. But of course, when you're diagnosed with low-risk prostate cancer, it's not just that you're buying lettuce and you're having to choose between rocket and endives and butter lettuce. These choices are actually a lot more serious. And we did original research, Alan and I, Declan, and also Mark Freidenberg and various others, to show that actually those people who are diagnosed with low-risk prostate cancer, that diagnosis is one of the most confusing diagnoses in cancer. And the reason for that is you can choose between active treatment, surgery, radiotherapy, brachytherapy. And of course, when someone's diagnosed with cancer, they hear the word cancer, and their first instinct is, "I want it out. I want to get it out of me." That's their first instinct. And I'm seeing a few of the women nodding in the room. It's also their wives' first instinct. I say wives, but it can also be, as partners, male or female partners. But it is when your loved one is diagnosed with cancer, you think, "I wanted to get it out of him." Then, of course, there's active surveillance. Declan and I have collaborated for a very long time on looking at active surveillance from when it was actually just a very new concept. It was actually quite a bit of a scary concept. Huge amounts of debate within the urology world about whether or not was it safe for men to have active surveillance. So it was really, gosh, how old I am, it's almost 20 years ago that it emerged as a viable treatment. In Australia, I think we are actually iconoclasts and we're world leaders. We're early adopters. We've got some of the highest rates of mobile phone usage in the world. We're early adopters. And as can be seen here, have I got a little, we adopted the recommendation that active surveillance can be offered as a treatment option for low-risk prostate cancer. We were before the US and before the UK. We know that 15 years survival rates are comparable for active surveillance with radical prostatectomies, surgery, or radiotherapy. Oh, and I have to say that this data is old because we now know that active surveillance from Declan's last publication is higher than 42%. It's close to 60%. It's still low in the US, and maybe that is because let's say there are a lot more private urologists who say, "I can work that out for you, mate." Okay. Active surveillance, though, is still not for everyone. When we did our original qualitative research, we found that all men were upset and confused and got conflicting information. That was pretty universal, and their partners. They were confused about the options. But even when they became a lot clearer about the options, active surveillance still was not for some men. It really depends on a whole range of things, such as your stage of life, your family situation, your need for certainty, your doctor's advice, what your doctor's saying. Well, there's a number of options for this, we can go through all of these options, or I can whip that out for you, mate. Your personal values. It may well be that you actually can't tolerate, you and your partner cannot tolerate actually living with cancer inside you. Your current health. It might be that actually you're reasonably, you're at the older end of the spectrum and you think, well, I'm not really interested in having surgery. That could, and also your emotional well-being. It may well be that you cannot deal with the anxiety of having a cancer remaining inside you. On the other hand, there's also that, uncertainty. You're either able to live with the uncertainty or not. That actually, some of the active treatment options result in bladder incontinence, infertility, certainly. If you are, and this is one of the men I remember talking to, he was a younger man who'd just recently repartnered with a much younger woman, and they were hoping to have children together. So actually having a prostatectomy was not going to particularly work for him because it may affect his fertility. Recovery, fatigue, the emotional impact, erectile dysfunction, and bowel issues. These are some of the issues that can occur with active treatment. So this is the paper that we published, and Alan is a co-author on this paper with us. He helped interpret the findings with us and has been along with us for the entire journey. But basically, that the decision-making process was extremely distressing and confusing, and there was need for emotional support. So what is a decision aid? It's when there is more than one reasonable treatment option. Sometimes in cancer, as within other chronic illnesses, really there is probably one best option, and all the other options are not are not going to produce good survival benefit or have a decent side effect profile. But really, with low risk prostate cancer, there is more than one reasonable treatment option. So what a decision aid is compares the risks and benefits of each option, and also helps clarify what matters to you most. It may well not matter to men, let's say, having erectile dysfunction because maybe that part of their life disappeared some time ago, but it actually matters a great deal to them that the cancer is out because they don't want to live with the uncertainty, or the converse might be true. And it helps you make this helps you make a shared decision with your partner, your family, or your treating doctor about what is the best option for you. So this is one of the quotes from the paper. He said, well, you should have your prostate out. When do you want to do it? Like he's trying to push me into making some sort of decision there and then on the spot. And that's when I, felt that this was not the way. Then I spoke to another urologist and we just decided to monitor it. This bloke had been on active surveillance 2 years. So we have created an online decision aid called Navigate. And this is a resource that is created by men, for men, and mainly contains men talking about their prostate cancer and their journey. And in fact, you will see the fellow in the Hawaiian shirt featured quite significantly on this decision aid. So why do we want an online? It's because it is accessible from home. There's wider dissemination. We can do regular updates. It also avoids the cost and logistics of actually trying to deliver decision aid, these decision aids with their paper. And of course, the rural and remote men often miss out. Permits greater tailoring and streamlining of the information. And now the over 50s are actually high users of the internet. And in fact, that date is 100 years from now. So. And also, the internet's a primary source of information for men. So this is the Navigate trial, and I'd also just like to acknowledge particularly PCFA here. Amanda Pomery, actually here, who's here in the room here and will talk to you. They house Navigate. So Navigate we used a process of co-design, and we believe that it's going to increase the adoption of active surveillance and reduce healthcare costs associated with unnecessary treatment of low-risk prostate cancer and substantially improve the quality of life of men. So this is a brief history. As you'll notice that we have gone a long journey, and in fact, I think creating the website nearly killed both Alan and myself. These are the aims of Navigate, which I think that I've talked about. And Declan has also been really strongly involved in this. And indeed, one of the issues that we're having with the Navigate trial is recruiting men to it. One of the reasons is that we want to capture men before they've made a decision, and then we also need to ask the urologist's permission to get their clinical data. And urologists who are on board with the trial recommend active surveillance, so a lot of men don't feel the need to go on because they've decided to go on active surveillance. The urologists who are of the "I'll whip that out for you, mate" type also don't want their patients to go on the trial. So Alan has been doing a fantastic job going out to men's sheds through the services, the RAF, trying to spread the word of this. It is a fantastic resource. There's around about 50 videos, mostly they're men. You can compare, as you can see here, the different treatment options. There's either two ways you can either self-refer of the PCFA, and you either get randomised to the Navigate website or the PCFA website, which is an excellent resource in itself. And then we've got an online self-referral. Now, I'd just like to finish up by saying thank you. The men who actually use the website have been sending us information to say thank you very much. It's been incredibly useful. And for any men that would like to take a brochure to advertise the study, if you know of men, you have contact with men who have been diagnosed with low-risk prostate cancer, we'd love to enrol them in the trial. Thank you very, very much. I'll leave these out on the table. Okay.
Any questions?
Yes.
Thank you so much. I've just been diagnosed with low-grade cancer. 3, 4, 7 last week.
I'm so sorry to hear that.
Yes, that's right. And I've had difficulty making a decision. And so I've had difficulty making a decision. I think it'd be best for me to join this.
Let me get you a brochure right now, sir.
I can check this out, by the way.
Let me get you a brochure right now. We will whiz you into enrolling you into the trial. Yes,
Oh my God,
I've just lost my doobie weapon. Okay. You'll have a brochure too. Please take.
Well, make sure there's some brochures there when you go out, so anybody else who wants one can pick one up.
Okay, thank you so much.
Any further questions? One more question. There being no further questions, thank you very much, Penelope.
Thank you very, very much. And I'm sorry.
Our next speaker should need no introduction because the brochures have been handed around already. She's going to speak about the role of peer support groups in the prostate cancer journey. So please welcome Dr. Amanda Pomery. Amanda Pomery is the Director of Support and Community Outreach at Prostate Cancer Foundation of Australia, PCFA. She's a registered psychologist and holds a PhD from the University of Melbourne in cancer survivorship, developing evidence-based standards for the selection and development of cancer support group leaders. Her role focuses on implementation of awareness campaigns and supporting men and their families affected by prostate cancer. Dr. Amanda Pomery.
Thank you so much, WCMICS, for having me here today. And I get to speak on my favourite topic, which is prostate cancer support groups. There are a lot of familiar faces in the crowd, so I know that this might be some information that we've covered on before. However, I'd like to give a little bit more detail and context, particularly in the conversations that we've had previously. So my role with PCFA is around support and community outreach. And just to give an overview of what we do within the organisation is that PCFA is a community-based organisation, but we're actually the national peak health body for prostate cancer in Australia. And our aim is really to reduce the impact of prostate cancer on all Australians. And we do that through three different mechanisms. One is around supporting world-leading research. So Declan spoke around the therapy trial, which is something that we're supporting, Navigate project, and also I'll be talking about some of the survivorship projects that we support as well. We look at implementing awareness campaigns and advocating on behalf of those with prostate cancer to improve their lives. And then finally, we look at supporting men who've been impacted by prostate cancer and their families. And we do that support through three different mechanisms. One is around providing evidence-based resources and information. The other is around connecting with support groups, which I'll be talking about in more detail. And we also have a national prostate cancer specialist nursing program where we've got over 45 nurses across the country that go and provide support and the central point of contact for men that have been diagnosed. So having a look at some of the facts, we've been talking about when we've been diagnosed, what the treatment options are, and then also making those decisions. But I wanted to bring us back to what are the actual survivorship rates that we've got for prostate cancer. And as you can see, in a year we've got approximately 20,000 men that are diagnosed each year. The good news is, out of that rate of diagnosis, 95% of men diagnosed with prostate cancer will live and survive for at least 5 years. So we've got exceptionally high survivorship rates. And that means that we've got over 200,000 men currently living after a diagnosis of prostate cancer. So for those that have just recently been diagnosed, what that means is you've got excellent chance with survival in terms of prostate cancer. However, not all circumstances are created equal. We have a difference that's going on between those in metropolitan areas and regional and remote areas, where there's actually a 5-year lower rate of survival for men in regional and remote areas compared to those in metropolitan. So although there's great figures in terms of outcomes, there's still much more that needs to be done. And I'll be talking in Toowoomba this week to talk about those disparities that are going on and how we can improve those outcomes for all men that are impacted. So there are some challenges. So once we've gone through the diagnosis and potentially the treatment stages of prostate cancer, then we need to look about how do we actually get back to living well. It's not simply about surviving the cancer, but it's also maintaining that good quality of life. And there's a significant group of men with prostate cancer that experience these significant challenges. So psychological distress, there are significant unmet needs when it comes to both the psychological and the sexual supportive care. There is disease and treatment side effects that need to be considered and the impact that that has on their daily lives. The main ones that come through from consulting with men in the support groups is fatigue, obviously erectile dysfunction, and incontinence. I think importantly it's good to raise the fact that this all has an impact on how you identify as a man and the impact that that has on masculinity as well. There are significant issues that getting back into life is made far more difficult. Within the specific population groups, there's also unique needs. So within the Aboriginal and Torres Strait Islanders, there's actually higher mortality when it comes to prostate cancer compared to the other groups. With culturally diverse groups, so those that might speak a different language other than English, there are huge challenges around accessing information and resources that can be understood, and we're also looking at health literacy issues. And as I've spoken about, the geographical disparities can also make a huge impact. Now, often when those that have been diagnosed with prostate cancer, you also have other comorbidities. So there's other disease activities that are going on that can also create challenges. So, for instance, it might be heart disease, there might be other cancers that you might be dealing with, there might be fitness and obesity issues, and sometimes it could be hip replacements or other concerns. So all of those things have a compounding impact on how well you can live and can have an influence on the treatment and support options that are needed. So looking specifically at the psychological distress, there are particular groups that are at greater risk when having a diagnosis of prostate cancer that can elevate the levels of distress that goes on. So firstly, those with an advanced diagnosis are going to have a potential increased risk of suicide. Those that might be on androgen deprivation therapy, I don't know who might be on in this group, but there are some, with that medication, there can be an impact on cognition, ability to recall information, as well as mood changes that can go on as well. For those that have a diagnosis at a younger age, it can also have an impact on the needs that are occurring at that time. So an example of this is I was aware of a man that was diagnosed at the age of 38, which was very young, and the impact that that had on the fact that he had to tell his workplace and speak with his work colleagues around the issue. He had to take time off of leave. That had a considerable impact on his financial stability. At the time, he had one child, but was thinking about having a second child with his wife. And so how his fertility would be after treatment was a consideration. And then you also have the fact that a lot of the time is how do you connect with others going through a similar experience when you're at that age. So the impact can have different consequences depending on the age and stage at which it occurs. And then finally, relationship status is something to have a think about as to the psychological distress that can occur. When a man is diagnosed, particularly with localised prostate cancer, it's been shown that the partner has higher levels of distress for the first 12 months than the man diagnosed with prostate cancer. So that's an interesting point and speaks to the reason why we often hear that it's very important that partners are included in the consultation and included in providing that resources and information, as well as access to that supportive care as well. For those that are single and perhaps might not have a partner, there is also an elevated risk of isolation and not having adequate support, and particularly when we know the challenges of going through various decisions and accessing the right support. So for those, it's really important that they connect with others so that they can increase their network of support. And something for us to be mindful of when we talk about getting support and access, that we also have to think about those men who might not be in a relationship and might be facing this on their own. So when we've had a look at psychological distress and the best evidence around how we approach this, there has been what's called a tiered model of care in recognising that not everyone would need the same type of support and the same level of support based on their circumstances or their background. So as you can see here at a very basic level, what's been found that those in a mild state of distress which is quite normal for those that would be given a diagnosis of cancer. But the universal care that's recommended to men that have been diagnosed is to have good patient education, look at the emotional supports that are available and the practical assistance, engaging in physical activity and exercise, screening for distress so that people can be aware of how elevated the concerns are, and referral mechanisms as required. But what I'll be talking about is around the peer support. So that's considered a really important component. Oh, 5 minutes, oh gosh. So you can see there's multiple levels of support that can be accessed. So when we're talking about peer support, this is something that really has been emerging and has occurred on an organic basis. It was first described in the literature back in the 1960s, and it spans a lot of the broader categories than just cancer alone. So often those, when there was the AIDS epidemic, where they needed to connect with peers, but also in managing Alzheimer's and looking at chronic disabilities as well as bereavement. Peer support groups has been shown to be very beneficial and something that the patients value to access. And the format has continued to evolve in the fact that now we're seeing online support groups, both through the use of Facebook, but also around online communities, which I'll talk about a little bit more. So the definition of peer support groups is quite varied when we have a look at the literature, and that's because no two groups are the same. But in terms of support, treatment and self-care, these words are used interchangeably. But overall, in the literature, it suggests that peer support is about face-to-face meetings of a small number of people who share a common affliction, habit, disease, or engage in a stressful life event. And the term can be applied to groups where there's varied structure and duration and leadership, content and activities. So the members certainly make those groups their own. And we've had quite an evolving space when it comes to prostate cancer support groups here. And the reasons why a lot of men and their partners attend these groups is clear. It's around reducing the isolation. It's the ability to be able to connect with others going through a similar experience to your own, to be able to receive and provide support. I do mention around providing support because a lot of the reason why people continue to attend groups is to have those connections with others and try and make their experience better than the one that they had for themselves. When you get a varied group of members, you also are able to see when you've just been diagnosed that there's actually a man who's been living with after a diagnosis of prostate cancer for 10, 15, 20 years. And I see in the audience that there are many of the men who've been living well after their first diagnosis. And that gives a real live sense of hope that it is not necessarily a death sentence that often strikes fear with a cancer diagnosis, that there are a lot of men that are living well and continuing on. Importantly, and I think a difference between the breast cancer support groups and the prostate cancer support groups is men tend to join prostate cancer groups, firstly to learn more about the disease and to find out more information. So you'll find that these groups often have guest speakers that attend, that have good resources and good referral pathways as well. Where the breast cancer support groups will often look to seek support first and then information second. But it's a great place in order to ask questions and discuss concerns. There's huge levels of effectiveness that we can see around peer support, around providing practical information. There's a high level of satisfaction that comes from participants, and there's an enhanced coping and increased quality of life that comes through, as well as the potential to increase health literacy. What is interesting is that cancer survivors make greater use of community-based support groups compared to those with another chronic health condition. So the use of peer support, not only in prostate cancer, but in cancer generally, is a high uptake. So I'm going to explain that obviously with PCFA we have a network of over 170 support groups across Australia. They discuss, share and talk about the impact of the diagnosis as well as ongoing management of the disease, and they also have member-specific groups. With the development, as I said, there is also an online community that we've got up and running in the last 3 years, and that's free to join, and we're currently over 3,000 members that are currently on that platform. And what we've done is we've mimicked what would happen in a face-to-face support group and brought it into an online space to give people greater accessibility and options as required. So there is a community forum where you can go and peer post with one another. There is also a video gallery where you can see videos around expert insights, just like you would with a guest speaker that comes to the group. And then the final component is a research blog, and that gives the latest updates in research in lay language so that you can be across the research in the field. So in conclusion, even though there are more men that are surviving prostate cancer, they may not be surviving as well as what we would like them to do. There needs to be addressing these unique and long-term needs across the spectrum, and peer support may be a preferred style of psychosocial intervention, and something that I would certainly encourage those that may not have accessed one to tap into local resources. They provide practical, social and emotional benefits to attending, and you can access this via PCFA's affiliated support group network and online community. And the way that you can see this is the online community has a direct link. However, you can also go to our website. We have all the latest evidence-based resources and information that you can access. There is a list of all the affiliated prostate cancer support groups across Victoria, of which there's over 32. And also we have a free call number if you would like to talk through any access to resources. We can post those out to you directly. So I think I've wrapped up as quickly as I can because I can talk forever on this topic, but I hope that's covered what you were needing today.
I think that's great, Amanda. Any
Thank you. I can vouch for this support group because the two people here from the Heidelberg and Essendon groups have been really helpful. The moment I found out my result, I had no one to talk to. They were able to help me, guide me. I went to one of the meetings, and I can vouch for what you said. It's very important.
And I know there's so many support groups here today, so if there was anyone that hadn't connected, please feel free to connect with others here or come up to me and we can show you where all of the support groups are. But it does make a huge difference, so thank you for doing that.
question? Thank you.
It is a long run.
Okay. Wait.
Catherine, I spoke to you earlier. I'm leading a support group in Box Hill. One of the things that I find that is lacking is that the knowledge of support groups is not getting around, especially the ones first diagnosed. And I just wonder whether there's, is this something that you're trying to approach and improve? Really, doctors and urologists should really know about it and promote that to their patients, because I researched a lot myself, and not everyone has the same background that I've had. So, thank you.
And that's been a long-standing issue, I think, is how we can streamline referral pathways into various social supports, including the support groups. One thing that we have started to notice is with the implementation of the prostate cancer specialist nurses, and I know we have one here today, that when a man is seen by one of the nurses, they make it their point to go through all the different options of support available to them. And so they are, I think, key in those referral pathways and making sure that that's accessible. We are noticing that a lot more men are doing the Google searches as well around how to access the best information for them. So having an up-to-date resource and selection process on our website is key, I think, to getting out and promoting those groups. We do have a convenience advertising program which has details in various toiletries across the country, which is something that we also like to do. And we also, the word of mouth is really important. When it comes to men's help-seeking behaviour, and if we take a step back, roughly about 8 to 12% of men diagnosed with prostate cancer will access a support group. Now, I know that does sound very low, but when we look at men's help-seeking behaviour across all different pathways, it's actually quite a high rate. So less men go to see a psychologist than they go to attend a peer support group. So what we've noticed is that roughly about 50% of men, when diagnosed, are looking online for that information. So that's why we're wanting to make sure that we're promoting that as much as we can in that online space, and attending and supporting these types of events as well. So I really appreciate what WCMICS are doing in promoting not only the medical information, but the full process of providing that information and support through to the patient support groups as well.
Other questions? In that case, can I just add a comment, Amanda, in terms of support? One of the key elements of the support groups for people going through this journey is the data. So, to every partner in this audience, thank you.
Perfect. Come on, give her a couple. Thanks very much.
The next speaker is going to talk about prostate cancer care plans. Dilu Rupassara is the Optimal Care Pathway Lead and responsible for the statewide adoption of optimal care pathways within the WCMICS Health Services. She's also responsible for overall strategic direction for the OCP Transformation Program. She has extensive working experience with multinational companies and universities, both in the UK and in Australia. I've worked with her for the last 6 months and she's great. Yeah.
Thank you, Ian. Thank you everybody for coming here today. It's a great pleasure to see you all. Before I describe the work that we've been doing in the prostate cancer space, I'll just give you a brief description of who we are and what we do. So we are the Integrated Cancer Services. So the Victorian Integrated Cancer Services are the Victorian Cancer Clinical Network, which comprise of a cluster of hospitals and associated health services that deliver services for people with all types of cancer within a given geographic area. We work in close association with the Primary Health Network, which is the primary care counterpart for us, and we work together with them to coordinate on this project. The role of the ICSIS is to build relationships with the clinicians, implement best practice models of care, improve the effectiveness of cancer care, and monitor systems and processes to improve the performance. So, like I mentioned, with all the health services, we work in close association with the clinicians so that we can, with them, address local opportunities for optimizing cancer care. There's 8 integrated cancer services in Victoria. 3 of them are metro ICSIS, and 5 of them are regional ICSIS. We are the Western and Central Melbourne Integrated Cancer Service, or WCMICS, as you have heard. And these are our partner health services that we work across with. So we interact with all the clinicians across these hospitals, and we work with them closely to provide the best cancer care that we can deliver to you. In Victoria, the State Department have tasked the ICSIS to implement the optimal care pathways. The optimal care pathways, or OCPs, are the national guides to the best cancer care for 15 cancer types. The pathways describe key stages in a patient's cancer journey from diagnosis to survivorship or end of life, and the expected optimal care at each of these stages. It identifies recommended care, services, and wait times. So all the 8 ICSs are working together to implement the OCPs in their respective health services. And the purpose of this is to standardize the care so that irrespective of where you're living or where you're receiving treatment, the care should be the same and should be optimal. So WCMICS worked in this space with the associated health services that you've seen before listed. And we conducted a baseline study to understand how to help people with prostate cancer. So we conducted surveys across Peter Mac and the Royal Melbourne because these are the highest, the hospitals with highest throughput of patients. We conducted audits of 85 patients across the various health services as well. And I've met a few of you here, so I went to the PCFA groups and held focus group discussions with them to understand what you would like to hear. So that work, the findings from that work were that patients reported lack of written information or written individualized information regarding their diagnosis and treatment plan given at the clinic. They do report that some clinics provide some sort of generalized information, like the Cancer Council booklets, but nothing in individualized information. And in some instances, some clinicians do provide some sort of written information, but the quality and the method of delivery was really inconsistent. So we took that information and we decided that we'll work in that space. I forgot to actually mention one of there's 8 principles that underpin the optimal care pathways. One of them is patient-centered care, and this is a health service that is responsive to the patient's needs and values. So we decided to work with that and focus our efforts in patient-centered care. We know that 40 to 80% of medical information is immediately forgotten by a patient at a clinician interaction. And we know that improving communication improves patients' health literacy, and improving health literacy improves health outcomes. So we thought that this was a good area to work with and to help people receive some sort of individualized information about their diagnosis and treatment. So we then decided to put a care plan together. But again, we wanted to do this having feedback from the people who actually use the system. So we did co-design, which is a methodology in the health services, employing all the stakeholders involved to come to a solution that is reflective of everybody's views. Initially, we created the care plan with the lung tumour stream at the Melbourne and Peter Mac, and which is now currently being piloted. That template is what we use to develop the prostate cancer care plan. And for that, we interacted with the various clinicians and prostate care cancer nurses. We held co-design workshops with a few of the PCFA groups, and with them we created what the prostate care plan would look like. It was an iterative process, so all the feedback was taken in as much as we could to create this care plan. So this is what the care plan looks like. It's a 2-sided form, and it's a tool that is aimed to improve the clinician communication with the cancer patients and empower patients to better communicate and engage with their clinicians. The first side of the sheet is about your cancer treatment, so your diagnosis. Actually, go into the next slide. I think it's a better one. So the top part of the first side of the sheet describes the cancer type. So the clinician will tick the box of your diagnosis, and we've got an image and the staging definitions as well, so that they can put that in for you, and a little diagram of what the prostate looks like for people who don't know what that looks like. The second half of that first sheet is what would happen next after the first initial appointment, and the clinician can write the name of the next clinician who you're going to be seeing, and the type of the diagnostic tests and the staging tests which you might be doing. The second side is about your proposed treatment. So it details the different treatment options that are available for prostate cancer patients, and the side effects as well. And the second half of the sheet, sometimes people do have questions that they want to ask and they forget to ask. They might be able to ask those questions there, and these questions as well, and further support and information on supportive care services available to people. So what we did is we created that care plan, and we printed hard copies, which I have here and I can distribute to everybody today, to take away and to share with other people that might be interested in and letting them know. And we provided these pads to the clinicians and the prostate nurses, and we, together with them, we established a process of delivering this to the newly diagnosed prostate cancer patients. So currently we're also investigating the process of integrating this form into the hospital's electronic system, and we have done that at the Western Hospital now. So, and we're currently working with the other health services to do that. So that was one thing that we worked with and we developed. The other thing that we have developed are a series of educational videos. Because in the feedback or in the surveys that we did in our baseline study, a lot of people didn't know about the different supportive care services that were offered across the different hospitals. So we thought that that was really important for people to know and for clinicians to provide that information too. So this is the series of educational videos that we have created. These are all supportive care aspects related to prostate cancer. And that's the link that you can access the videos from. I'll just run a little video so for you to see what that looks like.
Pro, and I'm a GP. So for many men with prostate cancer, the path to diagnosis and to treatment starts with a GP, when the conversation about prostate cancer testing takes place. For a man who has no symptoms suggestive of prostate cancer, current Australian guidelines recommend a man be informed about the benefits and harms of testing. This is so the man can then weigh up whether or not to proceed. This is called shared decision making, and advice is tailored depending on your age, the rest of your general health, and whether or not you have a family history of prostate, breast, ovarian or bowel cancer. However, for some men, prostate cancer is diagnosed after they present with symptoms that may be suggestive of prostate cancer. If you decide to be tested for prostate cancer, the first step is to have a blood test to check the level of PSA in your blood. PSA stands for prostate-specific antigen and is a protein made by the prostate cells that also enters the bloodstream. If the PSA test comes back elevated, it suggests something might be going on in the prostate that needs sorting out. It could be infection, inflammation, benign enlargement of the prostate, or it could be prostate cancer. your GP will arrange a referral for you to see a urologist. And when you do see the urologist is likely to examine the prostate via a digital rectal examination, and you may also be required to have an MRI to image the prostate. The urologist will then use the combined information of your PSA, the digital rectal examination, and the MRI to decide if you will need to have a biopsy of the prostate. The biopsy is when a sample of the prostate is taken by inserting needles into the prostate. The result of the biopsy will determine if there's cancer in the prostate or not. If cancer is found, there are two broad groups. The first group is if a small amount of very low-grade or low-risk cancer is found on biopsy. In this case, you may be advised not to have prostate treated, as it's very unlikely to spread or cause you any problems. However, you will need to be monitored closely by a specialist by a process called active surveillance, just in case a high-risk cancer is found or develops. The second group is if you have a biopsy and a high-grade cancer is found and treatment is required. For most men, the treatments are surgery or radiation. And the Australian guidelines recommend you get two opinions, one from a surgeon and one from a radiation oncologist. This is so you can weigh up the pros and cons of both treatments before proceeding down the treatment path. Your GP can help discuss these treatments and provide referrals. If you would like even a second or third opinion, that is perfectly fine, and your GP can help arrange this. A recent study in the British Medical Journal reported that continuity of care is associated with multiple benefits for patients. Continuity of care and holistic care underpin what GPs do. Your cancer specialists regularly update and communicate with your GP, and your GP is part of your cancer treatment team and can be there for you along the entire treatment path. If you have prostate cancer, here are some examples of where your GP will help you. In cases where localised prostate cancer has been treated at some hospitals, you might have some of your follow-up appointments shared between the hospital and your GP, and this is called shared care. And the hospital cancer treatment team communicates clearly with your GP about what is required. Also, if you have localised prostate cancer that has been treated, some hospitals will discharge you back to your GP after a period of time for ongoing follow-up. Again, the GP will know what to do. In other areas, your GP can provide ongoing support and education of what is going on with your treatment and discuss treatment options with you as they occur. Your GP might administer some of the injections if you are on the androgen deprivation or hormone therapy. Your GP can be a first port of call for any concerns, side effects or psychological distress, and can give advice regarding the impact of a diagnosis and treatment on you and your family members. They can work through accessing appointments and treatments and so on. Your GP can also assist with referral to allied health practitioners, for example, continence physiotherapists, exercise physiologists, psychologists, and they can also help to arrange GP management plans, team care arrangements, or mental health care plans. These are so that you can access Medicare rebates for allied health and psychological counselling if required. Your GP can also help to liaise and coordinate your care with all your other treating health professionals, just like a hub and a wheel. Your GP can also help you to link into the local community resources and services, and also use reliable online websites for further information and support. Importantly, the GP can keep an eye on the rest of your health, for example, immunisations, blood pressure, cardiovascular health, and other non-cancer related health conditions that may affect you.
Thank you. So that's one of the videos that you've just seen, and you can watch the others. They'll be available on our website, WCMICS website, and there's a YouTube channel there too. Thank you all for coming today, and I hope you enjoyed today's presentations, and I'll hand over to Ian. I've got to ask any questions.
No questions for Dilu? You've obviously solved all the issues. Oh, there is one. No, good.
Sorry, I know I asked a lot of questions, but I think this is important. You seem to concentrate on the western and central area. What about the other parts of Victoria, including other suburbs of Melbourne?
So like I mentioned, we are the Western and Central Melbourne Integrated Cancer Service, and there's two others. There's the Northern Eastern Integrated Cancer Service, covering the northeastern sides of Melbourne, and there's the Southern Integrated Cancer Service. So those three are, have their all the associated health services to cover the patch and the regions within the metro, and then the same for the regional as well.
Question?
Simply a question about the cancer nursing. I noticed it's for the public hospitals here, but in the case of, say, I went to the Epworth, would I be eligible to ring up for the nursing services?
I'm not sure, because these are all the public, so because we work in the public sector, these are all the public hospitals that are covered in our patch. So if the clinician or the urologist who's seeing you refers you to a public hospital, then you will be having access to these nurses. So I'm not sure how the private sector works.
Thank you. Question again?
Just to follow up on the first question, how are the various optimum pathway products from each of the various integrated cancer services around the state going to be integrated, or will they be different between each one?
So what we do is, so like the baseline study that I was explaining to you earlier, all the integrated cancer services follow the same kind of work. The department establishes the problem areas for a given cancer type. We take that and we assess whether in our health services that is a problem or not. And we do that by conducting surveys, auditing the health services and interacting with the clinicians. And therefore, each of the integrated cancer service can understand whether those problem areas are problems in our problem, in our region. And then we work, it's very targeted then, because then we only address the issues in our health service, and that's what all the all the ICSs are doing.
But the two-sided sheet, it sounds quite specific to your service.
No, these are all, so when we designed this, it was designed so we had a regional integrated cancer service contributing to this, and another metro one as well. So it's been, so we had feedback from a variety of sources so that it matched, or it was it reflected the local needs of the...
It was developed by three CSS working together, but it's now been adopted by the Department of Health for statewide implementation.
That's what I wanted to know. Thank you.
So the next, not for prostate, the next one will be statewide implementation. And so hopefully the prostate will become a statewide project too.
But it's also up to you guys. The more you promote it, and the more you tell
so this is
oncologists, your GPs to bloody well use it, the better it'll be taken up. Next question.
I'm not too sure if you can answer this question, but it probably relates to the whole day about the decision-making process. Now, if you've been diagnosed with, and your surgeon says you're an ideal candidate for surgery, then you see a radiation oncologist and they say, that you've been the ideal candidate for radiation, where do you go next?
Yeah, maybe I'm not the best person to answer that.
Get a second opinion from another
Yeah.
surgeon and another oncologist.
So you just keep going?
Yeah.
Yeah. But it's difficult because you're ideal for both, so...
At the end, it's your body, so make a decision.
Yeah. So
So
that's
the
something...
Navigate website, that'll help you.
Yeah.
General support group.
Okay, thanks.
Yeah, but you know, I think it's really important to see both a surgeon and a radiation oncologist, and then have a second opinion.
Get an
as well.
informed decision.
Yeah.
And just with diet, hasn't been mentioned today at all much about diet?
So that's the next event that we're hoping to host.
Oh, okay.
Hopefully you'll come to that one, and we'll be able to talk about all these other areas that there are too many areas to cover, and so we decided to talk about treatment options and pathology mainly today. The next one would be about supportive care and exercise and all these other areas.
Fantastic, thanks.
Thank you.
Any other questions? Well, we've heard about advances in imaging and targeted diagnosis, more complication than I think was there. We've heard how pathology can help the diagnostic process, and certainly things have improved in the last couple of years at least. We've heard about the importance of supporting care and the role and reach of support groups, and I encourage anybody who hasn't taken advantage of those to do so. And we've heard a little bit from Dilu about the development of better standard care pathways to assist us, and the CIVI project, which was the project produced at Cancer Care Plan Structure. So please join me once more in thanking most of the speakers.